This recording will go over part 1 of asthma. We'll start with the pathophysiology of asthma, which is what is going wrong in the body that's causing the person to suffer from asthma. So asthma is a chronic disease. So acute is something that comes on suddenly, right? Chronic is long-term. Chronic disease in which reversible airway obstruction occurs intermittently, reducing airflow. So reversible meaning the patient can have an asthma attack and then get better, and intermittently meaning it can come and go, right? So they have acute asthma exacerbations or flare-ups, and then they can go back to their normal baseline. Obstruction is due to two things: inflammation and hyperresponsiveness with bronchoconstriction, which these two things together, and even on their own, reduce gas exchange. Obstruction is in the airways, not the alveoli. And you can see in this diagram what's going on with asthma. So here in this bronchiole, the smooth muscle is open and wide, right? So all this area on the inside is where air can travel. With an asthma attack, that smooth muscle constricts. This is bronchoconstriction. And there's also inflammation that's making this lumen smaller, right? Here's how big it is over here. And over here, we're talking about this. So there's a smaller airway due to bronchoconstriction from the hyperresponsiveness, those smooth muscles closing or squeezing on the airway, and from inflammation that lead to decreased gas exchange. Inflammation occurs in response to the presence of allergens, irritants such as cold air or dry air, or any airborne particles that can irritate the airway, microorganisms, even some medications like aspirin and NSAIDs, and GERD, which is gastroesophageal reflux. So sometimes that reflux can then get aspirated and lead to an asthma attack. Increased airway sensitivity or hypersensitivity can also occur with exercise and upper respiratory infections. When asthma is well controlled, airway changes are temporary and reversible. So just a couple of definitions here. Inflammation is when allergens bind to specific antibodies, which start an inflammatory response resulting in blood vessel dilation and capillary leak, causing mucous membranes to swell and increase mucus production. Bronchospasm is the narrowing of the bronchial tubes by constriction of the smooth muscle around and within the bronchial walls. So again, both inflammation and bronchospasm causes that lumen or the center of the airway to become constricted or smaller. So in terms of assessment, we want to ask the patient if they've had any pattern of dyspnea, chest tightness, coughing, wheezing, or increased mucus production. We want to ask them if they've noticed their respiratory issues occur seasonally, if they occur with specific activities while at work. We're trying to figure out what the trigger to their asthma attacks may be. Is it more frequent at night? Why would you think maybe that one? That one's kind of a hard one to think about, but with the gastroesophageal reflux, so a patient who has reflux, when they're lying flat, the stomach contents can come up the esophagus and end up being aspirated, triggering asthma attacks at night. We need to ask the patient if they've had a recent upper respiratory infection. Huge one. Are you a smoker? And then finally, do we know wheezing in a patient who is not a smoker? Mild to moderate asthma may have no symptoms between asthma attacks. When we're looking at what we need to be noticing or what cues we need to look for to be on the lookout of an asthma attack in a patient, we want to be watching for audible wheezing, an increased respiratory rate, coughing, the use of accessory muscles, barrel chest. And with barrel chest, the anterior posterior diameter of the person increases. So the anterior posterior diameter is the diameter between the front and the back of the chest, and that increases with air trapping, giving the chest a rounder rather than oval shape. Chronic air trapping also flattens the diaphragm and increases spaces between the ribs. Other things you will notice in the patient with asthma or cues that you want to be looking for include prolonged exhalation. speaking with just a few words between breaths. They can't catch their breath enough to say a full sentence. And then hypoxemia, so just looking for, in general, the signs and symptoms of hypoxemia that include cyanosis, a change in level of consciousness, and increased heart rate. Moving on to labs and diagnostics, what are we going to be looking at to monitor a patient with asthma? And the first thing is ABGs, right? ABGs, we know, give us the most accurate information about a patient's oxygenation status. So in the patient with asthma or who's having an asthma attack, what you may see on the ABGs include a lower oxygen level, and the carbon dioxide level depends on where the patient is in the attack. Early in the asthma attack, the arterial carbon dioxide level may be decreased as the patient increases the breathing rate and depth. Then later in the attack, the carbon dioxide can rise, indicating carbon dioxide retention. We had listed here increased eosinophil counts as well as increased IgE, immunoglobulin E levels. So eosinophil is a white blood cell, and immunoglobulin E is an antibody that is produced by the body to fight against allergens. So both of these, eosinophil and IgE, are part of the immune system. And when I see these, I think of E for allergy. So I know that eosinophil, starting with an E, and IgE, the E's remind me of allergy. I don't know if that will help you at all. Another test that can be done is pulmonary function tests. These are the most accurate tests for measuring airflow in asthma. Pulmonary function tests are non-invasive tests that show how well the lungs are working. Pulmonary function tests can measure many different things, including lung volume, capacity, rates of flow, and gas exchange. The three types of pulmonary function tests that we'll talk about in regards to asthma are FVC, FEV1, and PEF. FVC is forced vital capacity. It records the maximum amount of air that can be exhaled as quickly as possible after maximum inspiration. So the patient's going to take as big a breath in as they can and then blow out as quickly as possible as much as they can. FEV1 is forced expiratory volume in 1 second. This records the maximum amount of air that can be exhaled in the first second of expiration. So they take their big breath in and they blow out as fast and hard as they can, and the FEV1, forced expiratory volume in 1 second, records just that first second of expiration. And then finally PEF, which is a peak, let me change this one here. There we go. PEF stands for peak expiratory flow. Peak flow measurement, peak expiratory flow measurement can show the amount and rate of air that can be forcefully breathed out of the lungs. A peak flow meter is often used. Here's an example of a peak flow meter. And again, the patient would seal their lips around the meter and exhale as forcefully as possible into the meter, and the little red marker would then give them a reading. They have other markers that let them know what their goal is versus what maybe problem areas would be. You know, if they got a bad number that they would need to either change their treatment or seek medical assistance. And we're going to end with then, what is our major problem with our patient with asthma? Well, it's decreased gas exchange, right? So we'll watch for those signs and symptoms or cues of the patient having issues with oxygenation. And interventions for asthma are all things that will fix this problem, things that will increase gas exchange.